By Dr ALOK Sati. He's a prominent cornea surgeon at my hospital only, and sir will be talking about correcting the refractive error from cornea to lens. Sir.
If we look into the good morning, everybody, the topic which I have been given by Colonel Pradeep is refractive procedures, cornea, and lens. The key concepts in this topic is why do we need this? Because we have to have increase in functionality and the quality of life of the patients. For this, we have to choose the correct tool, and then we have to reassess our decision whether we should operate such patients or not, and then we have to demand a skill set for it, like which machine, which lens will work for it. That's important. So broadly, if you look at, there are three kinds of procedures. One is cornea based, one is lenticular based, and one is the combination of these two procedures. So cornea based procedures, if you look at, there has been a paradigm shift since 1980s. Initially it was PRK. I'm not going before that because I'm going to those procedures which we are still doing. Then LASIK, and now SMILE and Contura. This is in the pipeline. So if you look into the PRK is normally done in patients in whom LASIK is contraindicated, and especially not contraindicated exactly, but to some extent, and we operate myopia to the extent of 3 to 4 diopter. And there is the Athens protocol for keratoconus. There also we perform PRK. And this is a short surgical video of the PRK. If you look at here, what we do
with PRK, your ophthalmologist removes a layer of cells called epithelium from the center of your cornea. These cells may be removed with an alcohol solution, a special type of brush, or with a specific surgical laser to remove a precise amount of corneal tissue. After reshaping the cornea, your ophthalmologist will place a bandage soft contact lens on the cornea.
If you look at what are the issues with the PRK, there are basically two issues with the PRK. One, the corneal haze, which persists for at least a month. It has been seen in some of the patients. And second, the epithelial healing. And these are the two limitations which provoked the innovators to look into another option, and that's what is the LASIK. This LASIK procedure, what we do is up to 10 diopter, though it's quite variable depending on the surgeon, depending on the corneal thickness. And we perform LASIK either by microkeratome or by femtosecond laser. And this is how the procedure is being performed. So after making a flap, now you see we are making a flap first, and then we are subjecting the cornea to the excimer laser. It is basically a sort of a keratomileusis what we are performing here. And this ablation is what creates, and then we again reposit the flap back. But the issue with this LASIK procedure is that the flap related complications can be performed in, there may be multiple occupational hazards, especially there are certain divers where it may not work, there are certain professions where it may not work. So the thought came, or thought provoked, that why not to have a flapless procedure, and that's what is known as SMILE. This is where we create an incision of small incision of about 3 mm, and we remove a lenticule through that 3 mm incision, and it gives high quality vision with less complication rate. And currently this is what is coming up in a big way, where it's similar to LASIK, but here a special topolizer is being used, and we mark 22,000 unique elevation points on the cornea. That's how it being modulated, and multiple aberrations which come up post-op, they are taken care of by these procedures. So if you look at our center, we have basically two procedures what we perform at our center. One is the SMILE and second is the ICL. And we do smile up to 10 diopter with astigmatism up to 5 diopter. And we have a very strict protocol at our center, like we take age more than 20 years, we perform cycloplegic refraction, we do the dry eye evaluation very properly, and then the corneal topography is very important because that's provide you the exact K reading whether a person is having, the ectatic disorder or not. If it is there, it's absolute contraindication, and then detailed fundus evaluation. And this is how the procedure is being performed. So this is how we perform smile procedure. We first create a plane at the lenticule level, that's a posterior level, and then this is the at the cap level, what we call it, then the side incision, and then we bring the patient's eye under a microscope, which is already there in the smile procedure, smile machine. Here the patient's cooperation is very important. And then this is the very small incision. We are first creating a plane anteriorly, then posteriorly. And after that, we remove the lenticule. This is how we have removed the lenticule. And this is a short procedure. Now, if you look at our experience, this is our experience from 2019. One side is showing the number of patients, and one is showing the number of patients attaining 6/9 to 6/6 vision. So if you look at, it's almost closer to the number of procedures that we have done. So this is the predictability of this procedure, which I want to highlight here. As far as complications are concerned, n number of complications have been enumerated in the literature, but to us, it is the suction loss, and that too in a few patients. We managed it considering the protocol of the machine. Sometimes we have gone against the protocol also, and that we are going to publish soon. Now, the other procedure that we do at our center is implantable collamer lens, where we normally do it, though we can do it even in the patients who are indicated for the smile, but normally we resort it to those patients who are not fit for the smile. And we have a very strict preoperative protocol like the smile, and the procedure is this. It's not working again. So what is most important in ICL procedure is that it's a loading, which is very important, and once it is being loaded, it's relatively easier to perform. But the most important thing is that we should know that the patient is under topical. We cannot afford to have iatrogenic cataract formation, so we have to be very careful. This is 3.2 mm incision. It's easy to perform through 3.2, unlike 2.8. And then we have to instill the viscoelastic into it. This is what we are performing, the toric ICL basically, under Callisto microscope. And this lens delivery has to be very meticulous and very smooth. And if you see, there is a hole in the right side that shows that the position of this lens is correct. And after that, you have to tuck in all these 4 haptics, considering the toricity into account. (178° the axis where you have to place it, and finally we have placed everything, and this is how it comes out. So till date, at our center we have performed around 58 ICL procedures, and to our surprise, most of them have got 6/9 to 6/6 vision on day one. We have done even one hyperopic ICL. The difference between hyperopic and myopic is that the hyperopic ICL doesn't have hole at the center, so we have to do preoperative PI, or even intraoperative PI also works. In 2 of the patients, we have found steroid-induced IOP rise, and no regression has been seen till this date. As far as complications, I have already rattled out. Thank you.
Thank you so much, sir. And the best part was that all the videos that you showed were in real time, and one could easily understand that these procedures, though they seem and sound very simple, are not so easy to perform. Thank you so much, sir. Any queries from the audience?
Sir, I wanted to know what is the minimum refractive error that you can take away with smile? What is your experience?
Yeah, 0.75.
0.75. And in that patient,
0.75 spherical. We have to have.
And do you think the new machine will help in avoiding complications such as suction loss or?
Yeah, now, currently the machine which we have is the old model. Now the new model has
Right.
come by Zeiss,
Yeah,
that is
800.
800.
Yeah.
So there the duration is just 8 seconds. So obviously, suction loss time will definitely happen. And now Silk has also come up by Alpha.
Yeah, J&J.
So do you have any experience with IPCL also, or you're doing only?
Yeah, IPCL I have done in AFMC, and what I have found, what difference I have found between IPCL and ICL is that ICL is a little thin, easy to manipulate inside the eye, and very easy delivery.
Okay.
And it's very, very pliable and very smooth, very shine, whatever you expect from a lens to have. Whereas IPCL is a little thick, so you always think it may hit
Okay.
the lens, normal lens.
Okay.
So that's, otherwise both work effective.